Hi, everyone. Thank you for joining us today. I am Dr. Brooke Messer. I'm an optometrist at Vance Thompson Vision, and I have the pleasure of spending the next half hour or so with Dr. Vance Thompson himself. I'm so excited to talk to you today. Welcome to Advanced Patient Care, an exclusive podcast series by Vance Thompson Vision. Our purpose is to keep you at the forefront of the optometry field through dynamic insights, practical clinical tips, and engaging expert discussions. Join us on a journey of continuous learning and professional growth as we delve into the latest advancements in eye care. Our mission is to empower eye care providers with the knowledge and tools to provide exceptional patient care. At Advanced Patient Care, we are dedicated to elevating eye care one episode at a time. All right, so as I said, I'm Dr. Brooke Messer. I practice in the West Fargo Vance Thompson Vision Clinic alongside our surgeon, Dr. Mike Greenwood, and fellow optometrists Nick Risbrut and Seth Stoffren. And again, Vance, so happy to be with you here today to talk about a mutual passion point. We're talking about myopia today.
Thank you, Brooke. It's an absolute honor to be here with you, and I have a ton of respect for what you are doing in our field to, not only help patients that need surgical correction, but how do we make this world a healthier and better place for those young myopes so they have the best visual life possible. What you're doing at the Myopia Control Institute, at Vance Thompson Vision. I look up to you, and I've really been looking forward to this conversation.
I really have too. We started talking about myopia together even before I was at Vance Thompson Vision back in 2019. I joined Vance Thompson Vision in 2020, and I found it really remarkable that, we had, of course, the mutual interest is, of course, best eye care, staying advanced, staying on top of technology, even just finding that we had a mutual interest kind of outside the norm of ophthalmology and, the co-management scenario or setup that we have here. And so I think I have you to thank for kind of help pave the way for the acceptance and the awareness of myopia control in our fields. And today, typically our podcasts are geared toward educating other providers. However, we've learned that there are patients that have kind of trickled in to tune into these podcasts as well. So just to kind of bring everyone up to speed, Vance, can you tell us, what is myopia? What are we talking about today?
Well, we're talking to a group of very sophisticated doctors who know what myopia is. But I think that this idea, especially axial elongation and myopia, not only obviously being an optical issue and a refractive error, but just what we've learned over the years about how it's also can become pathologic and the eye health issues. And I think we've all done a pretty darn good job of telling myopes over the years that they have a higher chance of cataracts and glaucoma and retinal issues. But the data that's happened by studying large populations and what happens with any increase in myopia increases the chance and rate of these different pathologies, how what we do now can influence their life so much in the next, decades of life. And so taking this from not just an optical issue, but an actual pathology, that how do we limit that axial elongation and those physical changes that occur and potentially negatively affect their visual life, and that we actually can play a huge role in helping them, is the part that fascinates me. And so I think that the main reason you are so focused on this, and I'm so interested in it and refer a lot of patients for myopia management and myopia control, is this pathologic side of it. And I'm looking forward to discussing it, because frankly, I'd like to see more optometrists talking about it with their patients, or either referring patients for it or treating them for myopia.
Yeah, and that brings up a good point about kind of bringing everyone more awareness, both like parents, patients, and providers as well. And so something that I've learned since being at Vance Thompson Vision is our model of care is, allowing those around us to do everything they can to the best that they can, then there may be cases where they're less comfortable. So maybe some are more comfortable managing myopia in some ways, but not in others. And that's kind of my goal being here in Fargo is, I want to be here to support our referral network that if they want to manage myopia with a certain method, say soft lenses or eye drops like atropine, but maybe not quite interested in orthokeratology. However, if they think they have a patient that is best suited for ortho-K, then that's what I'm here for. And I think it's really neat the way that the myopia management has grown here in Fargo, and that, the referrals we get are truly the patients that are more challenging. And we're seeing more and more patients being managed or having their myopia managed from a control aspect, the more we educate and the more we talk about it. So it's been really neat to watch that grow here in Fargo. And so just kind of building on what you said about, myopia, its nearsightedness, and something that's happening right now is the prevalence of myopia has doubled in the last 20 years, and it's anticipated to affect half the globe in 20. And for a long time, myopia was considered, at least high myopia was considered a condition of patients in Asian population groups. And so we didn't really consider Caucasians, largely where we're at in our demographics, to be affected by high myopia. But there's lots of data now showing, as you can see in this graph here, that patients of European descent and Asian descent were actually progressing in myopia at the same rate in both ethnicities. So we really can't, write it off to being like, oh, you only need to do myopia management if you're managing patients of Asian backgrounds. So again, the prevalence of myopia is just exploding, and there's certainly some aspect or some attribution to the COVID pandemic and continued near work and screen time and things like that in kids, where they do, now that we're seeing sort of the changes in those kids' visions post-pandemic, they are considering, that to be a big contributor to the increased rate of myopia that we see in our patients. So Vance, in addition to maybe the COVID pandemic, what do we know about why the prevalence is increasing?
Well, our world has, as you know, shifted close. If we think about centuries ago, we did a lot of things at a distance, and with the use of computers and mobile devices, and combining that with the genetic aspect, we're just seeing such an explosion. And if you think about half the world population being myopic by 2050, you just think about the children right now that you're taking care of are the children that are going to be adults and make up that, half of the population by 2050. So we are taking care of that exploding myopic population right now. And so this idea of more time indoors on devices and all these things that we can be helping people understand our issues, and that there's things we can be doing about it is just so powerful. But we need to be doing it right now. Consider this an urgent health issue for our whole wide world.
Yeah. And why do you think, you're just alluding into that? It's an issue for the world. And I wrote that here, global health and quality of life issue. Why is it a global health concern?
Well, I think a lot of it has to do with the fact that it's going to very negatively, affect their visual health on the long run. And a lot of these things that occur, especially, retinal issues and glaucoma, optic nerve damage issues, are permanent. Hey, you hear me talk about this all the time, and I know you do too, Brooke, but I also ask every patient if they rub their eyes. And I'm amazed at this younger patient population, and some of it I think has to do with, the modern day diet, but the dry eyes and allergies that occur even in this younger population. I'm very aggressive about asking every patient if they rub their eyes or those types of things. And sometimes I even say it before I introduce myself because I just don't want to forget it. I imagine when they push on their eyes, and I explain to them, how it, boom, it makes the back of their eye stretch. It makes the vitreous shift, posterior staphylomas worse, retinal detachments higher rate. So patients don't realize they can change their own refractive error, whether it's by too much time on their cell phone or their computer or eye rubbing. And so helping them with behavior modifications and some of the modern day treatment modalities that we're going to be talking about are so important to be talking about with every patient.
Yeah, I often describe it when we talk about kind of that globe manipulation. I think about a balloon, and if you squeeze it in the middle, it gets longer. And like the longer you do that, if you tie something around the middle of the balloon and then eventually you take it off, the balloon's going to be more elongated than it was to start with. And so, and you talk about like the stretching of the fibers, and I think that's kind of where the genetic aspect plays in. Is some people's genetics just allow for that little bit more stretchiness, and so they tolerate the ciliary body contraction that squeezes that midline of the globe. They tolerate it less, and you get that axial elongation from the stretching. I mean, maybe that's just me babbling, but that's where I kind of feel like that squeeze, that axial elongation, kind of in addition to the manipulation from eye rubbing and things like that. So couldn't be more on the same page with you on those types of topics. And I think something else that is important for providers to know is, even though the field of this is called myopia control and it's about progressing refractive error, or that's what it's kind of seems to be over time, but really as technology has evolved and the access to measuring axial length has grown, especially in optometry, that it's about axial length control. If they change a little bit more in myopia for whatever reason, cornea or lens, something like that, but their axial length stays the same, we kind of still consider that a win. So really it's about the axial length, and the change in the axial length, for the worse or longer is where these health conditions, come into play. And so, maybe over time we'll see that shift when we're talking more about not so much myopia control as it is axial length control, because that's the goal there. And, these studies here are, again, like focused around refractive error, which of course is tied to longer axial lengths. But again, I think over time we'll see more data coming out tied to axial lengths, reach, XYZ. This is when disease changes by certain rates. But, high myopia certainly comes with risk factors. And, at -6, we have a 5 times higher odds ratio for retinal detachment and a 40 times higher odds ratio for retinal detachment once you reach -10. And that's just exponential. And then myopic macular degeneration compared to emmetropes, myopes with -6 to -10 have a 72 times higher odds for myopic macular degeneration and 8 times higher odds for myopic macular degeneration once you reach -10. And when we talk about myopia here in North Dakota at our symposiums or other, educational events, Dr. Greenwood and myself look at each other because we're both, Dr. Greenwood is a high myope and I'm pushing that -6 number. And, we kind of look at ourselves. We both have, myopic spouses, and we're like, dang, like these are real things that this could affect us. And, being in eye care and being more aware of, it's like, who knew that myopia has its own macular degeneration? So this really hits home for me on like my kids and what I can do for them to protect their eyes over the length of their, over their life. So really, like this title of the slide says, every diopter matters. The risk for myopic macular degeneration increases by 67 every diopter. And that should really hit home to all of us as eye care providers.
It's just absolutely huge numbers, Brooke. I mean, and I like to talk about risk stacking, this idea of genetics being a risk, and this idea of environment being a risk, and this idea of eye rubbing being a risk. And when you look at these numbers, imagine, I mean, I know we'll be talking about treatment modalities in a little bit, but in the CARE study, if I can remember right, what the CARE study stood for, it was cumulative. It
Yep.
was cumulative absolute
Yes.
reduction in axial elongation. And so cumulative being, this idea of all these various risks. And then you take something like orthokeratology, and over a 7-year period compared to, kids wearing single vision lenses, there was a millimeter reduction in axial length in the ortho-K group. And so when you show this slide of these huge numbers that, I mean, 72 times higher, 8 times higher, just imagine if you can help someone over a 7-year period, millimeters
Yep.
less axial elongation, and what that does to protect the physical aspect of their eye,
Mhm.
it's stunning, and we can't let that happen.
I totally agree. And that, I mean, that 845 times, we don't see -10 a lot, but
Amazing.
there's a lot of people out there that are -10. And I measured my axial length this morning, and I'm a 25, and the that first kind of tier of elevated risk happens at 26 millimeters. So I may be like, we'll see. But I wish that we had that when I was younger. I wish we had these opportunities to control myopia and not be walking around a -5. So again, and that goes back to being younger. Something else that I think is really interesting in some of the data is that it's not the rate of progression. It's not the level of myopia. When you start talking about contact lenses for kids, the biggest predictor for high myopia is age of onset. And so for me, these studies here show 7 or 8 years old. When we have a myopia onset around age 7, so that's, first grade or so. And that was me, I was 8 when I've got my first pair of glasses. They're at a significantly higher risk for high myopia in adulthood. And the prevalence of myopic macular degeneration also goes up with high myopia. And this paper here kind of ties everything together that, the younger you are when myopia onsets, the higher your risk for myopic macular degeneration in adulthood. And so that's another kind of take home for providers. If you're a provider and you're watching today, what I would like you to take with you is that if you have a 7-year-old and they're a -1, you don't get to write it off. They're a 7, they're a myope, they're at high risk for high myopia in adulthood. That's the most amazing time to start treating, even if it's just something simple like an atropine drop in the evening. Again, it's the age of onset that we really need to take home and kind of hold that as gold standard when we start talking about myopia control.
Brooke, it fascinates me actually that you know your myopia and your axial length boom boom. And I think that we should be talking about them in tandem like that. The same care study showed that axial length, was up to 10 times more accurate than
Yeah.
refraction in monitoring progression. And so you can automatically get an idea for your risk factors based on your axial length. And so this early onset, measuring an axial length is a quite easy thing to do. And if you
Mhm.
don't have the technology, we do. And we're more than happy to do that for you. But when that early onset happens, get that axial length. I think of it kind of like if you have a spot on your chest x-ray, you sure like seeing 10 years ago you had that spot.
Yeah.
And so it's just a great way to monitor over time. And so to know that not only are they -3, but their axial length is, 24. And then in, a year or two, how is that comparing? If they're now a -5, what's happening with their axial length to monitor both, but realize the axial length is actually more predictive?
Yes, absolutely. And again, it's that stretching that brings in the disease states and everything that raise our concerns. And so, yeah, like if I can't get an accurate refraction, sometimes I don't get all worked up about it if I have axial length measurements. And so, yes, axial length is quickly rising as the gold standard in monitoring patients with myopia.
I think that what I also just want to say that I appreciate you saying, Brooke, is I just don't think we can say there is a safe level of myopia that you really want to understand. It's a risk factor in and of itself, and we need to know that axial length for that patient.
Yeah, and there's actually, I didn't include it in this PowerPoint here, but I have it in other myopia lectures that 30% of myopic macular degeneration cases are in patients that have refractive errors less than. There is no safe level of myopia,
Well,
especially in children because of that time for them to progress.
I've actually also heard the statistic that reducing the rate of myopia progression by 50% can reduce the prevalence of high myopia by up to 90%. And so when you talk about those huge numbers of increasing physical issues, you have it in your control to help that patient have a safer visual life.
Yeah. And I like to compare it to something like glaucoma. If you were able to affect their glaucoma progression risk by 90%, like everybody would be doing it. And that's the same with myopia. Like everybody needs to jump on board with that excitement. I'm like leaning into my screen because I just want to, just that the passion is just, you're doing such an amazing job bringing these important points forward. And it's just such a great opportunity. And that kind of brings in my next slide here is, Vance, you were inducted as president of the ASCRS recently. We know that you're a medical advisor to many groups and companies, and your passion is just showing through here on this discussion. Why does myopia make the cut when there is so much on your plate and so much that you do in ophthalmology? Like, how does it still kind of stick to the top for you?
Well, as you know, my specialty is refractive and cataract surgery, and I am really passionate about and performed a lot of clinical trials in laser vision correction, phakic IOLs, and lens replacement. Because of that, I see a lot of myopic parents. And I remember people starting to talk about myopia management as far as what I can remember really being in this century. But in the 90s, I remember seeing my first ortho K patients that were fit by area optometrists, and I was just fascinated with how there was this beautiful topography change, and these patients were either lower or no refractive error. And so originally, just as a refractive surgeon, I had a mutual respect for ortho K. But I remember when the CEO then of Euclid, his name was Bruce DeWolfson, came to Sioux Falls, knowing that I was actively involved in clinical research in cornea and laser and implants, and asked me to get involved with his company. And I said, yes, I have a lot to learn by this non-surgical way of helping people enjoy some time periods without being dependent on optical devices. And so my curiosity was there, but then it blended into starting, it actually lessened the rate of myopic progression. And even then, I wasn't aware of the risks. So there was progression of fascination with ortho K, and then this idea of people becoming less myopic, and then large groups studies of people having safer visual lives because their myopia was not advancing as quickly because of the ortho K. So it was kind of like one thing led to another. And as a result, I've been working with that same company for over 25 years. And so Euclid has been a very important, and that's what led to me getting involved with Treehouse when Gary Gerber came and asked me to be involved as an advisor with Treehouse to teach more doctors in eye care about how to deliver real quality ortho K. Being a subspecialist, I have a lot of respect for, experts. And I've always almost started doing ortho K myself, but every time I study it, there's so many nuances that even though I enjoy being an advisor to a company that delivers it, when I hear people like you who, is a world expert in it, I'm intimidated by, I don't think unless I was going to just do a very deep dive, I could do as good a job. So I refer them to people like you. But that's how one thing kind of led to another, and I got involved with myopia management. It started with ortho K.
I think that's really neat. And, your journey kind of validates mine in that, introduced to ortho K in optometry school and saw a few patients during my residency. And then I joined a practice with Dr. Jason Jedlicka in Minneapolis, and he was extremely passionate about myopia. In fact, has designed some of his own lenses. And, through learning alongside him and growing our myopia practice prior to moving to North Dakota and joining Vance Thompson Vision, I think the most amazing thing is, again, like seeing it work and seeing the parents, appreciative in how it's working. The kids love it. their vision's great, and then their eyes are staying stable. And then moving into some of the more advanced technologies where now it's really neat to be able to use instrumentation to create a fit simulation. It's kind of like the wavefront guided optimization and all the fancy stuff in LASIK, where you can kind of see like this is a very customized treatment. And that's where myopia management is going. Of course, now we can do all these simulations on our topographers to create a custom ortho K lens, and then you further customize their plan with adding in atropine or something else, and coaching around visual hygiene with time outdoors and, good lighting and things like that. So it is, once you kind of get into it, you're in, right? You're in, you love it, and just, so appreciate everything it does for our patients. So I think we've kind of established why myopia control matters and, why we do it. I'm just going to take a quick second to talk about a few of the modalities, and then we're going to dive into our mutual favorite, orthokeratology. Spectacle lenses for myopia control, currently not approved in the US, but they do have them in Canada and abroad. And the data is pretty good, actually. I think it's going to be a real game changer for patients once it is available in the United States, because there ultimately are still some parents that don't feel their children are a good candidate for contact lenses. And, they're a little bit concerned about switching into something like that. And it just improves the ability for all practitioners to provide myopia control options in their practices. So I look forward to, spectacle lenses being approved in the United States. It's kind of been like next year or sometime next quarter for about a decade, it feels. So it's like painfully slow, but looking forward to that. Soft contact lenses for myopia control. There are some that there is a one that is FDA approved. That's the MySight lens. It's FDA approved for myopia control. And there's another one that's approved for what they call myopia management. And then there's a handful of custom soft lens designs that can be done. And so I do think soft lenses have a place in myopia control, especially if maybe both parents wear soft contacts and they're just more comfortable with that for their child. And so all in all, soft contacts are a good option too, and they have good rates of control when properly fit and worn by the patient. And then atropine, it's a low dose atropine. There's various concentrations kind of being studied right now, with 0 concentration kind of leading the way as if it's monotherapy, and that's used at night before bed. And there's some good data around it. There's a little bit of how do we taper it off concerns to avoid rebound. But I do think that when a child is not a good candidate for a contact lens, atropine is still a great option. And there's a lot of energy being put into atropine right now. So hopefully as time goes forward, we get more clear data on the use of atropine, so that it can be a meaningful, well, it's still meaningful, but so that it can be even more prescribed with more, not accuracy, maybe you can help me with the word, Vance, but just, more confidence in the protocols, I would say, maybe a more standardized treatment method. Because again, I think there is a place for atropine in myopia control.
Right. And I think that, one of the beauties of these treatments is they are low risk, and you can monitor their effectiveness with the axial length and the myopia. And so I'm fascinated with, there's practitioners who kind of have their go-to to start with, and then they may add or try something different. My question to you, Brooke, is if you start a treatment modality, how long before you see that patient again and decide if you're going to add something to it? Like, for instance, if you're doing ortho-K, how often when do you kind of check their axial length again to see if you want to, for instance, even add some atropine?
Yeah, so our established ortho-K wearers, I see them every 6 months. And it for axial length measurements, as long as that looks good, of course, we'll maintain course. So if I see change at my first axial length measurement, so let's say I dispense an ortho-K lens, and then, we do the fitting, get them in a good spot, and then I see them for that mid-year axial length check. I don't always change course right away. Sometimes I'll have them back in like 2 or 3 months. Because we never know like what their course of progression was when we initiated that primary treatment. So I don't want to jump the gun too early and make them take an eye drop, if they don't have to. So if it's at the 6 month, I see change from the primary measurement, I may have them back at 3 months to see what's going on. If that is then stable, then I maybe won't make a change. But if it is further progressed, then that's when I'll consider adding atropine. And that's kind of, par for the course. So if it's, once we're established and we're nice and stable and then we see a dip, I'll usually bring them back at some point before the next 6-month check just to make sure that this isn't a weird measurement or something like that. And then I'll add in atropine. It's kind of like, managing a patient glaucoma. I don't want to tie them to a drop if they don't really need it. So I kind of want to prove to myself that, yep, this is true progression. And then we'll add in adjunct therapy. I'm going to talk a little bit about how my emmetropic eyes change in axial length compared to myopic eyes. And I think that's been a real game changer in evaluating those, what they call age match controls. And that's been really helpful in helping me decide if I need to add adjunct therapy sooner than later. Yeah. So again, we're going to talk a little bit about Ortho-K because that's kind of our mutual passion. And I think there's just so many benefits beyond vision, which we'll get into in a little bit. But Vance, do you want to introduce Ortho-K to us, please?
Yeah. So, this idea of using a reverse geometry lens to flatten the cornea is something that's been around for, quite some time. And we all know that, ear-tear interface is the most powerful focusing element of the eye, and the anterior curvature of the cornea is what defines the curvature of the tear film. And so if we can flatten the cornea, we flatten the ear-tear interface and we, lessen myopia. So this idea of sleeping in this reverse geometry lens to create this depression in a very predictable way. I mean, the accuracy fascinates me. The majority of the effect being epithelial. We're always trying to, we debate a little bit about how much of the effect is stromal, but the beauty of it all is it is, reversible. And that's one of the most powerful things that I think patients love about this non-surgical way of reducing the corneal curvature. Patients are oftentimes fascinated by the fact that they may have 3 diopters of myopia, but that their cornea has, let's say 45 units of curving power. And if we can, like I'll tell patients, lessen that, this isn't the exact math, but I try to keep it very, very simple in my patient discussions. If we can lessen that curvature from, 45 units of curving power to 42 by you sleeping in the contact lens, then, your nearsightedness is gone for a while and you can enjoy, a certain time period of spectacle or contact lens independence. And so that's my simple way, Brooke. I know that you have a, more detailed way.
Yeah, that is one thing that parents almost everybody does like kind of a shock in their chair when I say that you wear it at night and take it off in the morning and they can see. And so they're like, oh, he'll be able to run through the sprinklers or go swimming or play basketball with no glasses on. Like, oh, do they wear glasses during the day? Nope, you're corrected. And so sometimes I'll actually say it's kind of like temporary LASIK, where we change the shape of the eye and correct the vision for that time. I'll also use an example of like a retainer after braces. You wear the retainer at night, it keeps your teeth aligned, and you take it out during the day, and you just use that for maintenance. And that kind of hits home that concept to parents. But when it comes to Ortho-K and how it works in myopia control, basically we have these 3 images here, and I'll kind of talk through them from left to right. And so when we have a patient who's myope, uncorrected, you'll see that the image plane, which is the big arc in front of the retina there, it lands anterior to the macula, and that's what leads to that blur. So then we move to that middle image where when we add in some sort of myopic correction, whether it be single vision spectacles or single vision contact lenses, that whole image plane moves back to match up with the macula. However, the image plane is now posterior or behind the mid-peripheral retina. And there is some thought that the mid-peripheral retina holds the stimulus or the power of the axial length for the eye to grow longer. And so that mid-peripheral retina wants to match up with that image plane posterior to it. And that's what kind of stimulates that axial lengthening. So then you end up back at the first image where you have the mid-peripheral retina lining up with the image plane, but your macula is then not aligned and they're blurry again. And so that's kind of the thought around traditional correction, is that where you're competing with the macula and the mid-peripheral retina, and that promotes axial elongation. There are many theories to axial elongation related to myopia, and this is probably a piece of it, but again, this is how I like to explain it to parents because it's very easy to see when you kind of draw it out on paper. So when we do ortho-K, ortho-K actually curves the image plane. And of course, people who wear ortho-K don't actually see this. They don't see that peripheral vision change, because I kind of call it non-seeing or non-vision retina, where it actually pulls the image plane in front of the mid-peripheral retina and lines up the image with the macula. So now that mid-peripheral retina is happy, as is the macula. Therefore, we decrease that stimulus for axial lengthening. And that's been the best way for me to explain it to parents on how both ortho-K and custom soft lenses for myopia control. They have what we call dual focus or multifocal optics, and they work to change that image plane so that we can decrease that axial lengthening. Now, before we talked a little bit about your introduction into myopia control and your early fascination with ortho-K. For a while, maybe 10 years ago or so, there was a little bit of concern, or maybe more than a little bit of concern in ophthalmology on ortho-K. It was maybe the overnight wear, manipulation of the cornea. Can you comment a little bit on where you feel orthokeratology is at in ophthalmology now? Because I do feel that the tides are changing a little bit.
Yeah, definitely. And so I think that the large studies and the data has really led to that. This idea of ortho-K protecting the eye from axial elongation, and that over a 7-year period, someone in single vision lenses can end up with a 25 axial length, and if they are using ortho-K, it'd be a 25. To be that significant in and of itself is one of the reasons that I think ophthalmology looked at it. Yet ortho-K is kind of a two benefit technology. You get the spectacle independence, but you get greater eye physical health on the long run with much less reduction in retinal detachments and glaucoma and those types of things. But then when you look at large populations and see that the risk of what we all worry about, infectious keratitis, is less with ortho-K than it is with soft contact lenses. And we know that the soft contact lens infectious keratitis risk is something very acceptable. Of course, nobody wants it, but with proper care, we know it's actually very low. Same thing with ortho-K. So when you start to combine the large data that's come for improving eye safety with lessening axial elongation, and that the actual treatment modality has very low risk, and oh, by the way, there's also a big patient benefit. I think that's one of the big reasons that you have found that ortho-K has grown quite a bit in pediatric ophthalmology, referring patients for ortho-K, which has spread into the rest of ophthalmology and into the rest of medicine. I mean, pediatricians are now educating and coaching their patients to get their eyes checked and to look into things like this. And really heartening to me to see that this isn't just optometry talking about the benefits, it's also ophthalmology, and it's also the rest of medicine starting to really understand its benefits.
Yeah, and I agree that kind of the safety data has really helped support the use of ortho-K, kind of even across optometry too. There was concern in optometry as well for the overnight wear and everything that's associated with overnight contact lens wear. And I think the big difference with ortho-K, of course, is that they don't wear their lenses during the daytime, where continuous wear, day and night wear of soft lenses, the cornea never really gets that break. And then they're exposed to, the water in the shower, washing the face, things like that. Where in ortho-K, the cornea gets a break during the daytime, the lenses get full disinfection, while the lens is at home and the child is at school, and it doesn't have that water exposure that a continuous wear soft contact lens would have. Another interesting thing that I think as practitioners that we can kind of take to heart too is that our younger contact lens wearing patients are actually the most compliant when it comes to care and handling. You teach them how to use it. You rub the lens 15 times on both sides, you rinse it for 5 seconds, whatever your care is in care instructions are for handling their Ortho-K lenses. Kids don't know the cost of solutions. Kids don't think about cutting corners. All they do is they do what they're told when it comes to these lenses. And again, once kids get rolling with their Ortho-K lenses, they get over that initial adaptation period. They're seeing well. These kids do not want to come out of their Ortho-K lenses. They do amazing jobs of taking care of them. To be honest, like when it comes to any contact lens wearer, my scleral lens patients, soft lens, it doesn't matter. The ones that are kind of the most or the least compliant are those that have been wearing them for a really long time. And that's when they kind of start to get a little bit lazy with their contact lens hygiene. And so to me, it's checking in with my patients that have been using Ortho-K lenses for a few years or any contact lens. That's when we have to kind of remind them like, hey, make sure you're cleaning the case, replacing the case. And these are all parts of our every 6-month check-ins too. I'll remind the parents, hey, throw the case away, get a new one, run it through the dishwasher to disinfect it with the heat, whatever the method is to keep them compliant. Those are things that we talk about at every touch point to keep patients safe. But, again, thankfully the risk of keratitis or infectious keratitis is pretty darn low. And, thankfully have yet to see one in my own practice. So when it comes to Ortho-K in my clinic, I'm just going to provide a brief introduction on that. Our first visit is we'll set up a consult with the patient and the parents, and we'll do a quick refraction. We'll measure axial length, and then we'll talk about, where the child is at and possible recommendations. We talk about all recommendations, even though, again, like I personally love all the things that Ortho-K does for patients. We introduce all myopia management options, and the parents know their child better than I do. And so that helps us decide what modality we're going to use. But Ortho-K is a popular one, and I'm grateful that parents trust my recommendation and belief in the technology. We can use things like this top left picture here that you see. Some of our instruments can create these models of what the lens will look like, and we can create the desired tear film. And some lenses now can even be made quadrant designed. So I can change top from bottom, left from right, so that it really can align with all the asymmetries, with corneal astigmatism and things like that. So you get a beautifully centered lens with an even tear layer and a nice uniform treatment zone across the visual axis. So we'll use some technology like that to create this custom lens, and then they'll come back for the dispense. During the follow-up care, the most important thing in my mind is watching for corneal staining. As you can see in this lens here, it's maybe a little bit shallow or a little bit tight. There's not a lot of edge lift, and we don't need to get into all the nuances of fitting, but you can see that there's some corneal staining there in the center. And so this lens is, probably binding down a little bit and not providing, not allowing for adequate tear film thickness. Another little nuance that I think providers may be interested in starting Ortho-K should know is that even though it looks like there's no tear film there because that fluorescein pattern, it doesn't show any there is always a little bit of fluorescein in a properly fitting Ortho-K lens. So if I were to put a patient through maybe an anterior segment OCT, I would be able to measure a tear film underneath the entire cornea. So we're not changing the epithelium by pressure, we're changing it by those hydraulic forces. So if you do have corneal staining, that's not normal, and we need to make an adjustment to the fit to allow for more fluid to kind of pass over that corneal apex. And so again, corneal staining, that's what leads to breakdown, leads to infection. So number one always is monitoring for corneal staining. And when we're monitoring axial length over the course of someone's care, we can use modules like this. So this is a module that's added to our instrument that can measure axial length. And I just love this because we can see the bottom numbers here where it shows at each measurement point how much axial length was there. And then it graphs it out too. And there are other modules or there are other aspects within this module that can show us if the patient's at risk, considered a high progressor or a slow progressor. And we can also mark the time points with the correction modalities. So if I were to add in something to maybe Ortho-K or soft lenses, it would show that, hey, at this point you added a treatment method, and then we can see if that, graft trajectory changes. So it's really nice to have tools like this. And there are 3 or 4 different instruments out there now that can measure axial length and create, some reference points like this. And parents really find this very valuable as well, so that it's not just us saying everything looks good. They can actually see it on a chart, to see their modality and their investment in their kid working. The other image that we have here it's a paper comparing axial length changes in myopes to emmetropes, and it's age-matched progression. And so I use this table a lot. I have it pinned to my bulletin board here at my desk, and when I'm analyzing a child for their progression. These are 2 studies, one out of Singapore, and the other is the Orinda study, I believe. Yep, the Orinda longitudinal study of myopia. Basically, it says that these are on the left side, the myopes, untreated myopes at certain ages. This is what we would expect their myopia, their axial length changes to be year over year based on their age. And if they were emmetropic, this is what we would expect. And so if I see a 9-year-old and their axial length changed by maybe, I'm a little bit less concerned because they are matched with their emmetropic counterparts. And so it helps me decide, is their axial length change considered just like pathologic versus just normal growth related to being a growing child? And so having this type of data has been very impactful in how I manage my patients. This one here is kind of why I do Ortho-K, and I'm sure you see this too, Vance, over the years with your parents and families that have used Ortho-K, and that kids love Ortho-K. It is so hard to take them out of it if we had to for whatever reason. There's been a rare case over the years that we've elected to switch from Ortho-K to soft lenses. Kids using Ortho-K lenses, they report improved quality of life. They are more self-confident and willing to try new things. They're more likely to participate in sports. And they report higher overall vision scores compared to those that wear glasses. And it's like, when you see this, why would you not do it? These are huge parts of being a confident, successful development through those years that can be challenging, like, elementary school and junior high. So to have more self-confidence and be willing to try new things, those are just platforms for successful progression into adulthood.
Brooke, I find you'd be amazed at the thank you notes I get from parents that I referred their child for Ortho-K. And some of these thank you notes come years later, but these are the reasons why. It's just a beautiful way to build a patient and a family relationship.
It really is. It is. Yes. The family relationship is a huge part of myopia control. And I hold that, very close to my heart as well. Next, we're going to hear from one of my other gold stars, Owen, and he's going to tell us about his first experience with his Ortho-K lenses.
The first time when I put them in, I thought it was going to be kind of scary. But when I put them in, it was a little scratchy at first, but when I got into the routine, I was blown away by what it could do. I could see across the room. I felt like Superman, basically.
And that is the day-to-day with Ortho-K patients. I have another young guy about the same age as Owen, also about 2 years in on his Ortho-K. And he told his mom that if their house was on fire, the only thing he would grab are his Ortho-K lenses. And it's just like, how sweet is that? It just, again, if you need something to fill your cup, you got to do this. And so just to kind of wrap up today, Vance, maybe I'll let you just, if you have any closing comments and any other suggestions for docs that are listening today.
Just again, the patient education and how every patient you see, I feel needs to be educated about this. There's wonderful websites, there's wonderful materials, but we're helping people have a better visual life over the coming decades of their life. And so just the mere fact that you're watching this shows how much you care. And you have so many other responsibilities as a provider, but this is a big one, to take care of your community and educate them. Do the treatments yourself if you want, or refer them on. But let's just continue to increase the penetration of myopia control.
Yeah, well said. Absolutely. These are my two future myopes here on this one. We're still hanging in there. They're not myopic yet, but it's probably in their future given their parental genetics. And then I have two sites listed here, Myopia Profile and the Brian Holden Vision Institute, two excellent resources with vetted articles and data so that if you are using information off of these sites, you can feel really good about the accuracy in which you're offering to patients and their parents. Vance, thank you so much for taking some time to talk about myopia with me, and excellent job on your acronyms with the myopia studies. There's so many out there and it's hard to keep track of everything. But again, that's why I lean into some of these sites for my data too. And so I want to thank all of you for joining us as well. Such a great talk on myopia control. And again, please feel free to reach out to me if you have any questions about a specific myopia control case in your practice, or just curious about getting started. I'd be happy to talk to you. So thanks again, everyone.